Okay, welcome everyone. Thank you for joining today's webinar, The Science of High Sensitivity Troponins, from Research to Clinical Practice. I'm Jessica, a product specialist from Hytest commercial team, and it's my honor to host today's event. Before we started, I would like to mention that we have the chat function. Our audience can just ask the question through the chat function. I would like to review the agenda with you. First is the welcome and Hytest introduction. And then we will delve into a depth dialogue led by our keynote speaker and featured speaker. First, Professor Alan Jeffy will give the presentation of over 30 years of cardiac troponin. Where are we now? And after that, Dr. Ivan Kachuka will give the presentation of high-sensitive troponins for differential diagnostics of acute cardiac events. Lastly, finally, we will open the floor for questions in our Q&A session. So please feel free to send your questions as we go along, and we will address as many as we can. Hytest headquarters is in Finland. We operate across 3 continents with 150 plus employees globally. And with over 30 years of dedication, our company is committed to providing top-tier immunological reagents for IVD industry. We offer an extensive product portfolio with selected products serving as standard reference materials for the industry. Our products are built on a foundation of solid science, supported by more than 55 scientific publications. And we have a high industry engagement and quality standards. Our products reach to more than 55 countries, and enabling us to support laboratories and research initiatives worldwide. Here's our comprehensive product portfolio. Our product categories include monoclonal antibodies, polyclonal antibodies, antigens, sera, and plasma. We have as one of the main product areas, our cardiac markers are developed based on years of research in solid science. They have been used to help diagnose, monitor, and manage various heart conditions, including heart failure and acute myocardial infarction. As you can see, we have the pro-BNP, BNP, and anti-pro-BNP ST2 for heart failure, and the troponin I markers, troponin C, troponin T, FABP, myoglobin for AMI, acid development, for detection of the AMI, and other markers of cardiovascular diseases. Thank you for letting me briefly introduce our company. And now we will officially delve into our today's main topics. First, I would like to introduce Professor Alan Jeffy, our keynote speaker. Professor Jeffy is Professor Jeffy is from Mayo Clinic College of Medicine and Science. He specialized in cardiovascular biomarkers and acute ischemic heart disease. His key achievements include co-developing and validating the first cardiac troponin I assay and receiving the 2024 IFCC Award for contributions to cardiovascular diagnostics. He has authored over 800 papers, 5 books, and multiple book chapters. He also has chaired the biochemistry group for the universal definition of myocardial infarction effort since 1999. Today, he would talk about the history, advancements, and status of cardiac troponins as a biomarker in diagnosing and managing cardiac diseases, reflecting on the developments over the past 3 decades. Next to Professor Jeffy is Dr. Ivan Kachuka. Dr. Kachuka has worked in Hytest for 15 years, and he is He is specialized in immunodetection of cardiac troponins. In his speech, he will discuss the main biochemical features of cardiac troponins that have an impact on high sensitive measurement of these biomarkers in the samples of patients. He will also talk about new approaches in the immunodetection of troponins that may lead to more specific detection of myocardial infarction. Now I will leave the stage to Professor Jeffrey.
Thank you very much. Hope you can see my slides. It's my pleasure to be here. It's obviously very hard in a short period of time to review everything that has occurred over the past 30 years in the development of troponin. There are very good histories, one of which I've helped to write about this. And if one goes back, there was an early in the 70s, actually, a discovery of a troponin I assay that was reported by Cummins and colleagues, but it really was never commercialized and did not go very far. And it was not until Hugo Hytest in Heidelberg developed antibodies to cardiac troponin T, and subsequently Jack Ladenson and Gezer Bodar at Washington University developed antibodies for cardiac troponin I, that the field started to emerge in the late 80s and early 90s. I was fortunate enough to participate in doing the clinical validations of the original cardiac troponin I assays. Since then, as you're all aware, there have been a variety of troponin is the measure to use. It is axiomatic, but it should be appreciated that all the assays are different and that one cannot extrapolate numbers from one assay to the other. What we can talk about, however, are principles, and we'll talk a little bit about some of the principles that undergird our use of now what we would call high sensitivity cardiac troponin. But I would urge you that the numbers I'm going to show or others will show you are not ones that can be extrapolated from the slides to the assay you're using now if it's a different assay. One thing that is axiomatic that many of us believe strongly in is the fact that there are differences between men and women. In every normal range study that's been done, and this is a tabulation from the past, and there are even more studies now, the differences are quite substantial between men and women. And what it suggests is that it would be important to use sex-specific 99th percentiles. Excuse me, I want to go back if I can, and I'm not sure how to do that. Yes. If one looks, it should also be clear that although the 99th percentiles are all different, that there isn't even an ideal relationship in many instances between the cardiac troponin T and cardiac troponin I assays. This is just one analysis that comes from Wilde and the APACE group, suggesting if you look that when you use troponin T, that there is an offset here that is fairly substantial, that suggests, depending upon how one does the analysis, that there are not good correlations between these two. And that plays out in a lot of different circumstances, because if one is using one or the other as a gold standard, it obviously will skew the involvement of the other. In addition, it's worth noting that the 99th percentile values that have been developed, and although we now have criteria, it's not clear that those criteria have been kept all the time. And the criteria that have been developed, even so, have been developed with an eye toward being practical so that the IVD industry can implement them across all platforms. This is a slide from Paul Collinson's work that simply makes some important points. If one simply screens patients, doesn't ask any questions, you end up with values that are much higher than if one uses a questionnaire to eliminate those who have cardiovascular comorbidities, or to the right, all the way to the right, if you start to use things like NT-proBNP, hemoglobin A1C, as an EGFR and imaging. And the guidelines don't include imaging, but in point of fact, they lower these values as well. The bottom line is that it's very likely that the 99th percentile values in what we call normal are a little bit higher than they ought to be. And that's important for clinicians in the group who might be listening, because it means if you have a rising pattern and it comes close to the 99th percentile, that standing on the idea that 99th percentile is the end all and be all is probably not wise. Now let's see if I can go back as well here. If one looks, and early on I showed you there isn't a good correlation between troponin I and T, but there are a variety of different data that suggest that for acute coronary syndrome patients, I and T do a similar or comparable job, but in non-ACS patients, troponin T is much more apt to be increased and much more apt to be markedly increased than cardiac troponin I. And this may be one of the reasons why over time, if one looks, cardiac troponin T is a better predictor of mortality in patients who have non-ischemic etiologies for increases in cardiac troponin. There are some data to suggest that cardiac troponin I may be more apt to identify those patients with cardiovascular disease. So there are some differences here that are non-trivial. And one of those differences may be that there is some cross-reactivity between cardiac troponin T and skeletal muscle troponin. If one has a diseased skeletal muscle, it can re-express fetal isoforms that were suppressed during life, and with a return to ontogeny due to the injury, they can be re-expressed and detected. We reported that in 2011, and it does appear that there is some skeletal muscle abnormalities that may cause some of these elevations. It would be easy, however, to say, okay, troponin T is bad, just use troponin I. Well, we just need to be careful, because of late we've started to find that there are some increases in troponin I in a variety of situations, like possible ICI myocarditis after COVID vaccination, some patients with chest pain, that relate to the fact that at least for some of the cardiac troponin I assays, and this varies in magnitude depending upon the I assay, that there are so-called macrotroponins, which are conglomerates of troponin and immunoglobulins, usually IgG, that can end up causing false positive increases. Interestingly, at least in theory, these complexes could cause false negative values as well, but we don't see those because we don't study those sorts of things. We tend to care only when the values are elevated. Well, it's important because we now have high sensitivity assays, and they really do help clinically. I'm going to use the European Society of Cardiology 1-hour algorithm just to demonstrate some of the potential benefits. If you look all the way to the right in the rule out, it suggests that one can use a low value at the time of presentation to exclude myocardial infarction. And what these data suggest is Not that the low value rules it out totally, but that the low value tells you that the likelihood that over time one will elaborate sufficient amounts of troponin to meet the universal definition of MI, i.e. a rising and falling pattern with a value above the 99th percentile, is unlikely. This is a so-called single sample rule out. This is a meta-analysis that many of us participated in. If you take patients with normal electrocardiograms who have values that are low, and often these values change depending upon the specific assay and the specific percentage of the population one is interested in excluding, one can exclude myocardial infarction with very high sensitivity. And part of this is not just looking for the egress of troponin, but it comes from the fact that if one takes cardiovascular risk factors, all of the cardiovascular risk factors, with the exception of smoking, which none of us understand, have a tendency to cause small but graded increases in troponin. So a very low troponin not only tells you that an event is less likely, but also tells you that the underlying risk factors for atherosclerotic disease are unlikely present. The one caveat with this is that one needs to be careful, because if one comes in too early, as suggested by these data from the group in Edinburgh, if one comes in under 2 hours, that the sensitivity and negative predictive value of this approach is mitigated. So for patients who are at least 2 hours from the onset of symptoms, this is a valuable approach and can allow, in some settings, up to 30 or 40% of patients to be sent home early. In addition, we can use rapid algorithms. The ESC likes an algorithm that uses very small changes over an hour. We at the Mayo Clinic have been unwilling to do that, because as we look at our precision profiles for troponin T, and you see it there in the slide, the imprecision will not allow one to make distinctions between 3 and 5 in every patient. Now, what mitigates that is that usually heart attacks tend to have big signals, so that we're not in this small area where there could be confusion. And patients who don't have myocardial infarction are totally normal tend not to change very much. So clinically, it doesn't turn out to be as large a problem, but it can be a problem. And an example of that is shown here in a study that I participated in with Pete Kavsak, that has been published some years ago. I apologize for the citation. And what we basically did is we just let the samples sit on the table and redid them over a 3.5 hour period. And what you can see is that, in particularly when one is using the tight windows of the ESC protocol for 1 hour, one ends up with reclassifying patients, about a third of patients would switch diagnostic categories just by repeating the values, suggesting, as I have alluded to, that perhaps these values are too close to each other. The pushback has been, well, there isn't a lot of clinical data from clinical trials data, and I would take issue with that. This is a trial called RAPID, where and it's a complicated trial, so it would take a long time to get into the details. But in essence, they suggested that the representation rate of patients who were treated with this very rapid approach was about 15%. More critically, they showed that over time there actually was a signal for detriment. And one of the reasons for this may well be that many of these patients who in many centers get very good follow-up that may compensate if indeed there are some missed events there, may not be accomplished. This study was done in Australia, where follow-up, I am told, was not particularly robust. So we at the Mayo Clinic used a 2-hour protocol. This was also validated by the Hytest group. We use troponin T here, and we use a value of 4.04 to rule it to 10 to rule in, less than 4 to rule out. You can see nothing is perfect, that there is a clinical component that one needs to use. Nonetheless, the ability to use these assays to rapidly exclude or rule in often acute myocardial infarction is really helpful, because there are a very large number of patients who come to the emergency room. The frequency of MI is low. And so if one can triage these patients and move them either home or into the system rapidly, one burdens a large percentage of what goes on in the ED. And these are our data from when we moved from a standard sensitivity to high sensitivity. And again, shows a potential issue that we will consider going forward. And that's part of the reason for this symposium, which is, as we get more sensitive, we come to understand that although we may include a small number of additional people with myocardial infarction who previously, hopefully, had been detected and called patients with unstable angina, but that we're starting to see, again, more with troponin T than with troponin I, a signal for a large number of patients who have myocardial injury. We know that that is prognostically important, but the etiology could be extremely diverse, and I'm not going to show you a slide that will take up the entire screen because we don't have time to go into each one of them. This is important to keep in mind, and varies tremendously between Europe and the United States, and this is worth understanding as well. If one looks at European studies, the frequency of MI is down here at 15-16%. If you add unstable angina, which in many studies is 5 or 6%. Studies in the US, our study was one of the highest with an MI rate of 8%. So it's single digits. And that reflects probably how one uses troponin. If one uses it more frequently and more broadly, as is the case in the United States, and includes all comers, so-called, one is going to have a lower pretest probability to start with. And a lot of the differences that we see and arguments in the literature have to do with what the population is, because it will vary, and there needs to be some fine-tuning related to the population that you have. Now, there's a real problem with sorting, though, because if one looks at patients who have myocardial injury, and this comes from the high-stakes trial, they are often older women, they're often diabetics, and they have a very substantial death rate because often they're sicker than others. But also to the left, as you can see, they have a very substantial rate of subsequent ischemic heart disease complications, suggesting that embedded in some of these patients is substantial coronary heart disease. And there is the need for studies and ways to figure out which group of these patients have ischemic heart disease that could potentially be remediated, and those who have another mechanism. One way to start to consider that is by considering troponin itself. We think that troponin is mostly bound. There's a free early releasable pool. Some people have called that cytosolic, but all the protein is not in the cytosol. It's simply more easily releasable. But most of the troponin is bound to the structural proteins. So what one sees initially is the release of bigger complexes, troponin I and T, together, often in a TIC complex. There's some data that suggests an IC complex exists, and there may be some free chains, but they're bigger areas. Many years ago, these data were reported, which at the time weren't pursued very aggressively. And what we'll show you today is they now can be pursued, which is that when you have a patient who comes in with an MI and their values start to go up, that one sees larger fragments initially, and they are degraded over time. And the question is whether or not there is diagnostic information there. In addition, there may be pathophysiologically important information. Is a schema that was put together for a book chapter that Jennifer Van Eyck and I wrote. It recapitulates her data that what's found in human tissue as one of the first cleavages that occur is degradation of the 17 amino acids on the carboxy terminal end of cardiac troponin I. If one takes that moiety and overexpresses it in experimental animals, one has a cardiomyopathy that has calcium handling properties that are reminiscent of that which are seen with stunned myocardium. So there is both diagnostic information, but potentially biologically and pathophysiologically important information as well in these, if we could understand these fragments. This couldn't be pursued years ago because we didn't have sensitive enough metrics to look at all these specific forms. If you start to think about it, the assays for cardiac troponin are configured in such a way as to maximize detection of troponin, not to minimize or to look for these small subpopulations that exist, and that would take an additional level of sensitivity. Now, recently, this has been, again, started to be researched by several research groups, Dr. Meeks and Dr. Kachuka, who you'll hear from. And over time, we know, and this is an example with troponin T, but the principle at least is similar for cardiac troponin I, that one has a larger fragment, and that over time, with the antibodies that are used, one sees smaller and smaller fragments as degradation occurs. So one way to look at this, and these slides are courtesy of Dr. Wolfrick, is to make an assay that looks for what she calls long troponin. The Roche assay focuses on the central domain. These epitopes are close to each other. Again, so this maximizes detection. No matter what you cleave off, what is left allows you to detect the peptide. But one could have assays to these long fragments and develop an assay like this, and one could begin to look, if one had adequate sensitivity, to begin to look at all of these specific fragments. This is the long assay that they developed with antibodies, the C terminus and toward the N terminus, so that one could then look at the difference between the intact form of troponin, so-called long troponin T, and the smaller fragments that are elaborated in response to and part of the way in which the peptide is cleaved. Again, the same principle exists for cardiac troponin I. And with that, I'm going to turn the program over to my colleague, Dr. Ivan Kachuka, who's going to explore in greater detail how one might use these sorts of approaches to help diagnostically. And then we'll be glad to take your questions at the end. Thank you very much.
Thank you, Professor. Now, Dr. Kachuka.
Okay, thank you very much, Professor Jaffe, and for this great talk. And I hope you see my presentation now. Yes, and I would continue with troponins. And first of all, I wanted to remind that when we're talking about the measurement of troponins, we are not talking about the measurement of just separate proteins as troponin I or troponin T, because we need to remember that troponins form a ternary complex, and as Professor Jaffe has already mentioned, in blood, most of the troponins is present in a form of either ternary or binary IC complex. Indeed, immunodetection of cardiac isoforms of troponin I or troponin T is a golden standard of MI diagnostics, and truly recently many different high sensitivity and immunoassays were developed that measure either troponin I or troponin T with really high sensitivity and very high specificity. At the same time, we need to remember that, yes, here it is, that troponins are not the biomarkers of myocardial infarction itself, but the biomarkers of cardiac injury. And this state occurs not only during acute myocardial infarction, but also in many other conditions, including both acute and chronic conditions. And so the question is it possible to use troponins to differentiate acute conditions, including myocardial infarction, from chronic conditions that are accompanied with troponin rise? And actually, in my lecture today, I wanted to address this question and to show some data that probably first shows the first answers to this question. And so first of all, I wanted to start with troponin T and to show you this study of dynamics of troponin I, troponin T, and CK that was done in blood samples of patients that underwent the coronary grafting, and you see that the dynamics of troponin I blood concentration is different to the dynamics of troponin T concentration, while in troponin I shows just one peak that is its maximum is around 24 hours after the surgery. Troponin T shows a two peak dynamics. First peak corresponds to the peak of troponin I. It maximizes approximately from 18 to 24 hours after the coronary intervention. But there is also a second peak that you see takes place approximately after 80 hours after the myocardial infarction and restoration of blood flow. And so this indicates that probably the biochemistry of the troponin release from the myocardium, from the injured muscle, is different. And we and others have focused on this issue and studied this. So what we've done is we've studied the fragments of troponin T that is present in blood of patients with acute myocardial infarction, and using different monoclonal antibodies specific to the different portions of troponin T molecule, we have shown that in blood approximately 23 different troponin fragments are present, with the fragments that include the central part of the molecule, as well as the fragments that include on the C-terminal part of the molecule. Moreover, we saw that the composition of troponin T fragments, they differ in time, so it changes in time after myocardial infarction. And we observed an interesting thing, that the ratio of the central free troponin T fragments increases in blood in time, hours after myocardial infarction, while the ratio of the C-terminal fragments does not change in time. So this indicates that probably the second peak that was observed by our colleagues, and that what I showed in the previous slides, is formed by the central free small fragments of troponin T. This was also confirmed by the ELISA studies that we've done when we were using several immunochemical assays specific to the different portions of troponin T molecule. And again, we saw that the ratio of the of the troponin measured by the assay that is specific to the central part of the molecule increases in time, while the ratio of the long troponin T decreases in time after myocardial infarction. Again, this might prove that the increase, the second peak of troponin T that we see after myocardial infarction, is mostly formed by the central free small troponin T molecules. There was a big work that compared the forms of troponin T in different conditions, and it was shown that indeed the forms different of troponin T are different in various conditions. So it was shown that only small free central fragments, same fragments of troponin T, are present in blood in the end stage renal disease and after after hard physical exercises, namely marathon completion. Also, our colleagues have developed several immunoassays that are specific either to the central part of the molecule or to the troponin T that they called a long troponin T assay, to the bigger fragments that include the C-terminal part of troponin T, and they compared the ratio of short troponin T and long troponin T fragments in blood of patients with myocardial infarction and end-stage renal disease, or with patients with Takotsubo syndrome. And they have shown again the difference in the presence of different troponin T fragments in blood of patients with acute myocardial infarction and Takotsubo syndrome. And this might indicate that the measurement of long troponin T fragments in blood of patients is more specific to the acute events, namely non-STEMI or STEMI, than to the other conditions. As for the troponin complex forms that are present in blood of patients, we also see the differences in the troponins that are present in blood of patients after myocardial infarction. And we see that these forms are also changing in time after myocardial infarction. If at early hours after myocardial infarction, troponins are present in blood mostly as a ternary complex, full-sized, high molecular weight ternary complex, and low molecular weight ternary complex with partially cleaved troponin T. Later, approximately after 30 hours after myocardial infarction, troponins are present in blood mostly as free troponin T fragments of different size, and also binary troponin I, troponin C complex. If we're talking about the comparison of troponin forms in different conditions, I can share you the data of these two studies that were already accepted by Clinical Chemistry Journal, and I hope would be published soon. In the first study, we have designed four different assays specific to the different forms of troponin complexes. So one assay measures all ternary troponin complexes and IC, binary IC complex. The other assay measures the large size ternary ITC complex that comprises large fragments of troponin T. The third assay is specific to the total ITC complexes that comprises both large troponin T and short fragment of troponin T, while the fourth assay is specific to all troponin T that is present in blood of patients. And in the second study, we have compared the ratio of these different forms of troponins in blood of patients with either acute injury, which was acute myocardial infarction, and with chronic disease, which was chronic heart failure and cardiomyopathies. And we saw the huge difference in the ratio of ternary ITC complexes in blood of patients with acute injury and with chronic injury, where the ratio of ternary complex was much higher in patients with acute injury. In the same time, if we compared the ratio of troponin T in blood of those patients, with the picture was absolutely different. The ratio of troponin T was much lower in patients with acute injury than in patients with chronic disease. And this indicates that indeed there could be a possibility of differentiation between acute and chronic conditions, although we totally understand that these are only the first studies and much more studies are needed in order to be completely sure. The present data indicates that the measurement of ternary ITC complex or large or full-size troponin T fragments could be beneficial in terms of discriminating between acute and chronic conditions. And I thank you very much for your attention and would be happy to answer your questions.
Thank you, Dr. Kachuk, for the speech. And yes, there was a little bit technical issue that we encountered, but happy to see Professor Jeffrey coming back to answer our audience questions. I'm happy to see we have got a lot of questions from our audience, and I will just start it with the first question. What additional information do we need to begin to figure out how to use the new advances intelligently? Please, Professor Jeffrey.
Yeah, I'm glad to start. This is an exciting area and one that has a lot of potential, but there are some issues that we need to think through. First of all, as I showed you in the talk that I gave, some of this can occur in myocardium. So we need to be careful because if indeed one has an event that occurs in myocardium and processing can occur there as opposed to in the blood, that could change the timing. And in particular, for those of you who are clinically oriented, you know that most of the troponin will come out, for example, if one has a totally occluded vessel only after reperfusion occurs. So one could be confounded by that, and that's an important issue for us to take into account. Secondly, there may be differences in mechanisms. So it's been shown that, for example, with exercise, that they tend to be small fragments of troponin, even though they come out acutely. So that it may turn out, since we think that many of the etiologies of release of troponin with exercise relate to acute pressure overload of the RV and a preload dependent mechanism whereby the cells die due to apoptosis, that it could turn out that different mechanisms will cause different fragments. And we need to know that to be sure that we don't inadvertently think all of this is due to timing. And there are a variety of other issues. Thrombin tends to cleave some troponin, and that could be a real problem since we know that a lot of ischemic heart disease is associated with high thrombin activity. Finally, we need to be really careful, and Dr. Kachuka can speak better to this, to make sure as we start to get to really highly sensitive approaches to doing this, in particular with antibodies, the likelihood of minor interferences causing big differences is high. So we need to be very careful just to make sure that the way in which these assays are configured, and I'll compliment Dr. Kachuka on the fact that thus far they've been very careful about this, don't end up with some analytic problems that could lead us astray.
Thank you. Dr. Kachuka, we would like also to hear a little bit from your thought about the question.
Yeah, thank you very much for this question, and thank you very much, Dr. Jaffe, for your comment. And I can only add that, and indeed, we need to. I totally agree with the saying that we need to be very careful with the measurements of troponins because they are present in blood in very, very low concentrations, and there are many factors that influence the measurement and could influence the final result, the final concentration that we observe, and the diagnosis as well. And our job is to develop such antibodies and then such immunochemical systems that could exclude the influence or exclude as much as possible the influence of such factors, including, I can also mention the heterophile antibody interference, which could be huge, or also HAMA antibody interference, rheumatoid factor antibody interference. And so this should be also always considered when you're working with, when you're working on the development of immunochemical systems.
Absolutely. Thank you. Here is the other question. What additional clinical studies are necessary?
I think we have to be careful about this because, for example, in ischemic heart disease and acute myocardial infarction, a fair percentage, we could argue how much it is, and it varies from study to study, of the damage that is caused can be caused by apoptosis. So if indeed apoptosis elaborates different fragments than ischemic heart disease, what one might see is a profile that might have a variety of different fragments that would need to be gone through to make sure that we could, in some ways, localize the etiology. So there could be some overlap. And what that means is that we need clinical studies in really well characterized individuals who have, hopefully, to start with, just one disease and one unique etiology for troponin release, so that we can drill down and look at all of the parameters that affect them, and then slowly moving toward the more complex circumstances where there rates to be some overlap. Because, for example, patients who have heart failure related to ischemic heart disease may have their heart failure and some elaboration of troponin related to subendocardial wall stress and increased preload as one mechanism, but can also have recurrent ischemic heart disease if that's the etiology of their event. So we need to have these very well categorized human studies that utilize patients that are really well studied.
Thank you. Thank you, Professor Jeffrey. Dr. Kaczurka, do you have any additional points to add in?
No, as I said, those studies that I've shown you in my presentations were only just the first, I would say, first studies made on troponin fragments, and I think from a biochemical point of view, it would be really interesting to compare other groups of patients with elevated troponins, but without acute myocardial infarction, and to evaluate the ratio of different troponin fragments in these sampling as well. And I hope that these studies would be also performed and would be performed soon.
Thank you both. This is thank you for your excellent speeches. And unfortunately, today we are running out of the time. I would like to thank our audience to join our webinar, and thank you, Professor Jeffrey and Dr. Kaczurka, both of you. But we will send our recorded materials and also the answers for the questions that we haven't answered yet. Thank you.
Thank you very much. See you.
See you.
Thank you. My pleasure.